Hello, my name is Nihar Vavale, and today I'll be presenting our case, life-saving device with a life-threatening complication, LV perforation after Impella CP placement. Neither me or none of the presenter of this case has any relevant financial relationships to this. Impella devices are currently being increasingly used in high-risk PCI and cardiogenic shock. They provide short-term hemodynamical support, but are not without the complication. Our case illustrates this complication and highlights the lesson from the clinical vigilance. Our patient was 63-year-old female with hypertension, diabetes, hyperlipidemia, coronary artery disease with multiple prior stents. She presented with severe chest pain for more than 12 hours. She stopped taking her prasugrel a month prior. Her high sensitivity rose from 20 to more than 125,000 within 12 hours. An ECG showed ST segment depression in lead V1 to V3. An echo showed ejection fraction of 40 to 45% with reasonable abnormalities. She was quickly started on the aspirin loading dose and with prasugrel and heparin. An emergent cardiac cath was performed. Here we have an LHC video which is demonstrating 99% calcific restenosis of the proximal LCX and extending into the obtuse marginal branch. Here you'll be able to see right-sided coronary having a normal flow. She underwent PCI with 2 stents and developed a cardiogenic shock, for which she was started on norepinephrine vasopressin drip along with the Impella CP placement for additional support. This is an Impella device in the left ventricular cavity. Immediately after the Impella placement, she developed hemodynamic collapse, and bedside echogram showed large pericardial effusion with diastolic collapse of the right atrium and right ventricle. A visible definite tract entering the pericardial space could also be seen. This is an echo showing large pericardial effusion with the right ventricle and right atrial diastolic collapse. An emergent pericardiocentesis was performed. A subsequent left ventricular grab showed migrated Impella CP head through the friable LV apex. A combination of continuous aspiration of pericardial effusion with autotransfusion back into the central circulation with mass blood transfusion protocols was performed. This is an LV gram revealing the Impella's tip migrating through the left ventricular wall. At this point, patient was transferred to the surgical OR and the Impella was removed intraoperatively. Left ventricular perforation was repaired with the bovine pericardial patch and IABP was placed for additional. Despite successful patch report, IABP support, adding dobutamine epinephrine in addition to the ongoing vasopressor support, patient developed cardiopulmonary arrest with sustained VTAC, which was further complicated by shock, liver, acute kidney injury requiring CRRT, thrombocytopenia, acute blood loss, anemia requiring multiple transfusion. On postoperative day 5, patient succumbed to multi-organ failure. This case emphasizes that although the Impella CP devices are life-saving supporting cardiogenic shock, it carries the risk of LV perforation, especially in patients with recent large infarction in friable myocardium. And recognition requires high suspicion when abrupt collapse occurs after the device placement. Echocardiography is critical in rapid diagnosis and emergent surgical intervention is life-saving but often associated with poor outcomes. Data from the MAUDE database report over 1,200 complications related to Impella use, with death occurring in more than 12% of the cases. There has been total of 8 reported cases of LV perforation published into the literature to date. 3 of them did not survive the episode. And in one of the cases, LV perforation happened after the Impella removal. Below are the references to those cases.